Our methods for developing and testing this molecular classifier was to use a genomic approach, and in this case it's an exon array over the whole transcriptome using a microarray technology, so gene chip technology, and then basically training this so that we could classify these fine needle aspiration biopsies into a series of categories using a multidimensional algorithm to could accurately train and test this molecular classifier to be validated to distinguish benign versus what we are calling suspicious nodules in this study. So our methods for developing this molecular classifier were what we call an iterative process, which what we would do in this concept is to train, starting with tissues and then adding in fine needle aspiration biopsies, this molecular classifier. Tell it what is truth. Tell it what is cancer and what is not cancer. So we would train that, and then we lock that training set and apply it to an original small first test set and see how we do. Based on how we do with the first test set, we then reopen that training set, add our test set back to it, and retrain the algorithm to continually get better and better. And so we have a larger training set number 2, and this is again locked, and you see this actually then went against a test set of 24 indeterminate biopsies, which has now been published. Daria Chudova is the first author, and this was published recently in the Journal of Clinical Endocrinology and Metabolism. So now we unlocked this test set, added it back, and we added more samples to our training set to have a final training set of 426 samples to do this final iterative training on our classifier to get it as good as we can get it before doing this test for this presentation. So we locked our final classifier for validation and then tested it against these 43 prospectively collected samples that have gold standard histopathology overread, and that's what went into this study. Just to show you what is the composition of the final training set, and you can see on the left-hand side there are 2 categories of malignant and benign at final histopathology. And you can see the bars represent what went into this training set, either tissue, fine needle aspiration biopsy in our early studies, the ex vivo post-surgical studies, and our preoperative fine needle aspiration biopsy. Some of these that were in our study so we could make sure that the way they were tested, we were accurately testing them in this training set. So the validation of our final molecular classifier, once this was all done, we again had a negative predictive value of 96%, which is excellent. We also had a sensitivity of 95%, a specificity of 63%, and a positive predictive value of 57%. So we again felt that we have met these criteria of having a high negative predictive value, but having a high enough specificity to say that if it is suspicious for malignancy, we're going to have a high rate of malignancy in these biopsies. So in conclusion, if we go back to this 6-category cytopathology Bethesda system and we look at this indeterminate group, what we feel we now have been able to do is take these indeterminate biopsies and apply this molecular classifier to either say it's benign, and we believe now with this 96% negative predictive value, this is good as it is as good as an expert cytopathologist saying it's benign, or moving it into a suspicious category, which is a high enough risk of malignancy to now warrant surgery. And if we apply this molecular classifier, many of these indeterminate biopsies, the patients can avoid surgery if the molecular classifier returns as benign. And finally, we'd like to just acknowledge the many colleagues at many sites that you can see here from the 49 trial sites that have contributed these many patients and also cytopathology slides and collecting surgical pathology to make this study possible. Thank you for your attention.